as you all know, the cardiac surgery itself is a very challenging subject, and very few people are really interested for doing it. Although I choose this subject, it's not as a pesha, rather it's as a nesha. So really there's a lots of fears in cardiac surgery. As I already mentioned in previous talk, there's a death, the quality of life and pain. There are lots of things are come in mind to the patient, family, and after that, after a proper counseling, even at the last they ask always what is the risk. So that is why very few people are really interested to become a cardiac surgeon. So now the historical note. Before the proper technique of cardiac surgery, actually we already diagnosed cardiac disease, but we are not able to treat them because we had no option of maintaining the circulation. As we all know, the cardiac heart is our central organ, and it maintains the circulation and keep body alive. So the first technique in cardiac surgery comes, that is OL technique. The atrial septal defect was repaired in a beating heart with a tube connected with the right atrium, and it's just a blind suturing of the intra-atrial septal defect. And unfortunately, many of a time in that particular era, they mistakenly closed the tricuspid orifice. The patient died. Now, another technique is cross circulation. As we all know, if we really want to do open heart surgery, we need to stop the heart fast. So if we stop the heart, who will maintain the circulation? So many people, or at that time, actually baby's heart was stopped with the help of mother's heart as a bypass machine. And then come the hypothermic circulatory arrest. The patient body temperature cool down, and at a certain level of temperature, the heart will stop. And at a few minutes or very few times, that operation has to be completed. So this was just a massacre, because this is not actually the proper way, but yes, this is the historical growing up of the cardiac surgery. And after that, in 1952, John Gibbon, he invented the cardiopulmonary machine. Now, even that, there are lots of complications happened in cardiac surgery, and that's why the cardiac surgery was not so interested or not so growing up. And after that, 70 years of struggle, hurdle, and lots of innovation and skill improvement, the advancement in technology and skill development, the huge changes happen in cardiac surgery. Now, the cardiac surgery gradually become a popular, and it becomes safety and quality of life. Now, the patients, when the cardiac surgery is established as a treatment of heart ailment, now patients started to choose their technique, and then it should be cosmetic. Although cardiac surgery is a very complex operation and complicated operation, but yes, patient demand it should be cosmetic, and hospital stay should be less, and we need to join in our duty in a very faster way. So necessity creates invention, and MICS comes. Now this is the minimally invasive cardiac surgery. Why it is important? Why the people want? Actually, if you see, minimally invasive cardiac surgery has its own advantage, that is a small cut that really want the, every patient, and there is a quick recovery and quality remains same even with the conventional invasive surgery. Now it requires training, not only the surgeon's training, it also requires staff's training, training of nurses, training of everybody, because MICS, there are small things that can lead to a major difference. So instrument, the many instrument required, that is not really the normal one what we use in a conventional way. So I went to have my training in UN Mehta and took my training in MICS. Now the patient selection, the MICS can be done in every operation, but not in every patient. That is very important. If we wrongly choose any patient for MICS, we will be in trouble. So exclusion criteria should be there, and it depends, it is actually relative, because excellent skillful surgeon can do anything, even redo CABG can be done with MICS, but as we are in very young age or young in cardiac surgery, we cannot do CABG in MICS. So it's that relative indication. But initially we should not do MICS in redo operation, emergency operation and composite operation, both CABG as well as open heart or valve replacement surgery with a kid with a complex congenital heart disease. These are the particular operation we cannot do in MICS in initial phase. Now what operation we can do? We can do AVR, MVR, double valve replacement and congenital ASD, VSD, tetralogy and bypass. Now how we can do? The basic difference of MICS and the conventional surgery is the cut. The conventional way, we usually cut the midline sternum and whole length. This is the conventional way, but in MICS we just cut in a small intercostal space. That is the basic difference. However, the anesthesia technique is almost same, and cannulation technique, there are few difference, but we should cannulate in an open heart patient and cardioplegia for arresting the heart. Now patient position is important, because we should keep in mind that patient may need to convert the from the MICS to conventional way. So the position of the patient should be in such a way so that in requirement we can convert the position as well. Now this was my first patient. I, after my training completion, operate in a newly married couple. They was feared of the cardiac surgery, and these young patients have ASD. Unfortunately, the atrial septal defect was not fit for device closure. Other way we can do it in a device closure by our cardiologist colleague, but it was not. So we did this operation through MICS. So MICS had, although we tell that MICS has a less pain, but still we are open the chest through the intercostal space. This is a painful, and pain is not so small or little than the normal way. So another is the small scarring is very important. This is the cosmetic value why people want MICS, and we usually call it recovery will be faster, although there are some few patients they might have some delayed recovery and hospital stay is shorter. This was the patient after discharge in the first follow-up patient, and the next patient MVR. There is a 49 years female. She was having rheumatic heart disease with severe MR, and we operated this patient with mechanical valve, 30 size, and that was the third one. The MICS MVR again. This patient was rheumatic heart disease with severe MS. We operated her with mechanical valve, MVR with 27 size valve. Now the operation theatre, everybody should be oriented with this technique, because small things may mistake and may lead to massacre. Now, apart from the patient selection and patient choice, this team approach is very important. So minimally invasive, not without any complication. It has its also its own complication as well and consequence. So most importantly is the conversion. There is the very key conversion or any pathetic for the patient as well as the doctor. We took the patient for MICS, and in some point of time we decided that yes, it is not possible to go ahead and we should convert it. So prior to taking the patient in operation theatre, we should counsel properly that patient may need to conversion. So informed signed consent is very important, and this was one of my patient, Marble Mistri, and he was very scared of his doing his operation, but somehow I convinced him to do operation, and I did his operation myself. And so what are the problems in MICS? There are lots of things we should consider, because MICS it's not so easy in a holistic approach, because patients, apart from patient selection, operation, the main problem come in the practice is the financial burden, because most of our patient in India, particularly in West Bengal and rather in Murshidabad, they are financially very poor, and the cost of MICS in a corporate hospital is really high. It's not the same as conventional procedure. Apart from that, surgeon skill is a long learning curve, and expensive instrument, and overall cost I already told you, and it is not really affordable to everybody. So another operation I did, this is actually ultra MICS, as we can tell you, that is sutureless AVR. As we already know that valve replacement surgery, we need to remove the diseased valve, and we put a new artificial valve in that patient, rather is the parallel of the TAVI. So sutureless valve replacement, what is that? We need to stop the heart, we need to cut the aorta, we need to remove the aortic valve, cast as well as calcium, hold the things, and we put the valve, and without suturing it with the native tissue, we just put it in a collapsed position and release it. It just place in the position and it will act. So this was my first sutureless AVR operation, and this is the gentleman, and he was I think 75 or 77 years old. So TAVR, as you all know, the aortic aneurysm is not only a very complicated disease or severe disease, its operation is very much complex, and there are lots of mortality, morbidity associated with the main operation of aneurysm operation. And really we are happy with our cardiologist colleague. We can do this operation without even anesthesia of the people. We can put stent graft with TAVR technique, as this can be done by cardiologist in cath lab and with the help of cardiac team, cardiac surgery team, heart team approach. Now the TAVI, as you all know, this is the exclusively the most recent advancement in cardiology in cath lab, but yes, this is again the minimally invasive, as we already know that even with the MICS techniques, patient need to do anesthesia and need to arrest the heart and cannulate and circulation CPP machine, all are can be avoided with this good and novel technique. So now the most recent, as my another colleague told, that artificial intelligence, we can do operate in a patient even from Murshidabad at the patient is at Kolkata. So this is the recent most advancement. We can do operation with the robotic technique. So this is the future target. And take home message, minimally invasive surgery, although is a very novel technique and very acceptable cosmetically, it accept everybody, but the selection should be in a proper way. Every operation can be done, but not with all patients. So thank you.
Any question from the audience? So, thank you, Dr. Amanul Hoque, for beautifully representing the precise conception of minimally invasive cardiac surgery. Beautiful presentation. So,
Thank you. Thank you.
জানলাম